Pulmonary blood flow must exactly match cardiac output under all conditions. This tight coupling between heart and lung function means that any disruption, whether cardiac or pulmonary, rapidly affects oxygen delivery. Understanding how pulmonary blood flow is measured and distributed helps explain exercise physiology and pathologic hypoxemia. Pulmonary blood flow can be calculated using the Fick principle. This relates oxygen consumption to the arteriovenous oxygen difference. This principle assumes steady state conditions and is foundational to cardiopulmonary physiology. Clinically, it underlies cardiac output calculations in catheterization labs and exercise testing. So let's calculate. Using the provided values, oxygen consumption divided by the arteriovenous oxygen difference yields a pulmonary blood flow of 5 liters per minute, which corresponds to normal resting cardiac output. Walking through this calculation reinforces the physiologic link between metabolism, oxygen extraction, and circulatory flow, concepts you'll apply repeatedly in both inpatient and outpatient medicine. So again, these were the given values. The goal is to solve for Q and plug and play. So we have Q here on its own. We can plug in VO2 at the top, 250. Then we can divide by 20 minus 15 over 100 milliliters of blood, which ultimately, if we do this calculation, we get 5,000 milliliters of blood per minute or 5 liters per minute, which is typical cardiac output. Now, where does that blood flow to? Pulmonary blood flow is not evenly distributed throughout the lungs. Due to gravity, perfusion is greatest in our lower lobes because blood is going to flow down lower, and it's going to progressively decrease up towards the apex, towards the top. This vertical gradient has profound implications for ventilation, perfusion matching, or VQ matching, interpretation of imaging, and understanding why certain lung regions are more susceptible to disease processes. Regional pulmonary blood flow is largely dictated by gravity and vessel compliance. Because pulmonary vessels are thin-walled and highly distensible, blood preferentially pools in dependent regions of the lung. As a result, both ventilation and perfusion increase from the apex to the base, but perfusion will increase more steeply. So we have a greater increase of perfusion at the base than we do ventilation at the base, despite both of them being higher. At lung bases, ventilation is approximately 2 times greater, but blood flow is around 5 times greater at the bottom of the lung compared to the apex. During exercise, increased cardiac output and capillary recruitment partially offset these gravitational effects, which improves overall gas exchange efficiency. This graph highlights while exercise increases total pulmonary blood flow, the relative distribution pattern does still remain similar, more flow at the base than at the apex. What does change it is that the absolute perfusion at all lung levels is going to, this is partially due to capillary recruitment and distension, is going to increase. Clinically, this explains why exercise improves oxygenation in patients with mild lung disease and why pulmonary limitations often only become apparent under stress conditions. The pulmonary circulation uniquely responds to hypoxia with vasoconstriction, not vasodilation, which feels counterintuitive. When an alveolus becomes hypoxic, nearby pulmonary arterioles constrict, shunting blood toward better ventilated alveoli, because alveoli's goal is to get oxygen in them. So we really don't want gas exchange to occur in an alveoli that doesn't have oxygen. This mechanism is called the hypoxic pulmonary vasoconstriction, or the HPV. This will optimize ventilation perfusion matching locally, or VQ matching locally. While this is beneficial in focal disease, widespread hypoxia, as seen in conditions like COPD or high altitudes, can cause global pulmonary vasoconstriction and pulmonary hypertension. Here we can see how reduced alveolar PO2, oxygen partial pressure, and increased PCO2, carbon dioxide partial pressures, trigger vasoconstriction in the affected region. Importantly, the signal for vasoconstriction originates in the alveolus, not in the blood. This contrasts with systemic tissues, where hypoxia induces vasodilation because we're trying to get blood that's high in oxygen to tissues that are low in oxygen. But in the lungs, we're trying to get oxygen into the blood. So an alveoli that doesn't have a lot of oxygen, we really don't want a lot of blood flow to that region. Understanding this difference between systemic and pulmonary circulation and oxygenation is really critical for interpreting diseases like ARDS, acute respiratory distress syndrome, where regional hypoxia leads to significant shunting of blood, and refractory then hypoxemia. The net effect of hypoxic vasoconstriction is redistribution of pulmonary blood flow toward ventilated alveoli. This is preserving arterial oxygenation. However, when hypoxia is diffuse, in conditions like pneumonia, for instance, or high altitudes, as I mentioned, this adaptive mechanism becomes maladaptive. This can increase pulmonary vascular resistance and right ventricular afterload. This is a key pathophysiologic driver of condition like cor pulmonale. We'll stop here. When we come back, we will look at respiration and blood circulation.